Happy anniversary. Hi everybody, it's Ryan here and welcome to our 60th Mnemonic Together in Internal Medicine. I hope you and your family are well. I just want to place on record my sincere thanks and appreciation to every one of you for supporting my channel and for subscribing and liking and sharing. God richly bless you, and I pray that the content that we cover in internal medicine is going to hold you in good stead in days and years to come. I hope you guys are enjoying the content. Right. So the topic for today is diarrhea in the immunocompromised, and the mnemonic is magic. Okay, but first up, let me favor you with a couple of dry diarrhea jokes. Actually, they're quite runny. So do you know that doctors in general say that 4 out of 5 people suffer from diarrhea? That means 1 person enjoys it. 10 facts about diarrhea. Number 2 may surprise you. And listen, on Monday we start Diarrhea Awareness Week. It runs until Friday. Guys, just some quick scriptures just to encourage you this beautiful Friday morning. I want to talk about the power in your words. The book of Proverbs chapter 18 verse 21 says that death and life are in the power of the tongue, and those that love it shall eat the fruit thereof. Paul, when addressing the Philippian church in Ephesians chapter 4 verse 26 says, "Be ye angry and sin not. Let not the sun go down upon your wrath." James 1 verse 19 says, "And be quick to listen, slow to speak, and slow to become angry." I pray that will be our desire. All right, so let's talk about diarrhea and the immunocompromised. There are many reasons why people get immunocompromised, right? They could be on steroids, it could be HIV associated, it could be because of malnutrition or primary immunodeficiency syndromes, it could be because of solid organ failure or etc. There are lots of causes why people are immunocompromised. So in general, infective causes of diarrhea amongst immunocompromised people includes magic. So M speaks to Microbreedium. A is amoeba, speaking to Entamoeba histolytica. And watch out, these patients may also present with amoebic liver abscess as well, right? G is for Giardia lamblia. I for iosporiasis. And C can stand for Cyclospora or Cystoiospora, right? So let's just talk about diarrhea for a bit. So we know the definition of diarrhea is at least 3 bowel movements per day or at least 200 grams of stool per day. And acute diarrhea is defined as that which has a duration of less than 2 weeks, whereas chronic diarrhea is by definition greater than 2 weeks. Now, we usually split the differential of diarrhea into inflammatory or invasive etiologies versus non-inflammatory. And under inflammatory or invasive, usually the patient manifests with fever and bloody diarrhea and tenesmus. And here we talk about invasive infections versus inflammatory versus ischemic colitis versus radiation colitis. And examples of invasive infections are our beloved Salmonella, Shigella, Campylobacter, Yersinia, Enterohemorrhagic E. coli, Enteroinvasive E. coli, Vibrio parahemolyticus, not cholerae, parahemolyticus, Clostridium difficile, and Entamoeba histolytica. Under inflammatory causes, the usual culprits, ulcerative colitis and Crohn's disease, right? Non-inflammatory causes of diarrhea can be non-invasive infections versus medications. And the non-invasive infections can be split into bacterial, viral, and parasitic. And bacterial, here we speak about Vibrio cholera, your typical rice water stools, right? Staphylococcus aureus, Bacillus cereus, Clostridium perfringens, Clostridium difficile, which we'll talk about another time. And then we get the other 2 flavors of E. coli being enterotoxigenic and enteropathogenic E. coli. There's a whole host of viral causes, the most common being rotavirus, norovirus, and CMV, which is cytomegalovirus. All right, and also the C here also stands for CMV as well. Sorry, I forgot to put that in. And parasitic causes of non-inflammatory diarrhea are Giardia, Cryptosporidium, and amoeba. Medication-wise, we speak to antibiotics, laxatives, and chemotherapy. Important to draw on diarrhea and some of its associated syndromes. So Salmonella may cause septicemia in patients who have sickle cell anemia or AIDS. Shigella usually precedes reactive arthritis. Campylobacter has this beautiful association with Guillain-Barré syndrome in 10 to 30% of patients. Yersinia can give you mesenteric arenitis, erythema nodosum. So that's also a differential of erythema nodosum, hey? Polyarthritis, reactive arthritis, bacteremia, and may actually mimic appendicitis. Okay, and then clinical features in diarrhea and the history. You want to characterize the diarrhea in terms of the duration, the frequency, the volume, whether there's blood associated with it, which makes it dysentery, or whether the stool is floating, right? Infectious contacts, recent food intake, abdominal pain, past medical history in that of IBD or lactose intolerance, Medication history in the way of laxatives and antibiotics, and travel history as well. On physical exam, you need to check your vital signs and check for dehydration, check for abdominal tenderness, and perform a rectal exam. Inspect a stool sample if available. Special note on Salmonella and Campylobacter: although they are classified as inflammatory, patients usually only develop fever with these infections and severe diarrhea and not bloody diarrhea. How do we investigate acute cases of diarrhea? So your basics have to do with the labs and the microbiology. So your labs is your full blood count with the differential urea and electrolytes. A special note for your creatinine, check whether the patient's in pre-renal or intrinsic renal failure. Do your lactate as well if the patient is hypotensive. Microbiology speaks to stool culture sensitivity. Check for ova and parasites. Check for Clostridium difficile toxins A and B, and viral culture. Special testing on the stool is fecal leukocytes. You can do a fecal calprotectin if you're thinking about IBD, fecal lactoferrin, Giardia toxin, fecal blood. You want to also do endoscopy in the way of a flexible sigmoidoscopy or colonoscopy, right? For management wise, symptom control is IV hydration is the name of the game, and antidiarrheal agents are used only if it's non-inflammatory diarrhea. To this end, we can use bismuth subsalicylate or loperamide 4 milligrams stat, and then 2 milligrams, which each reduce stool to a mass ceiling dose of 16 milligram per day. Then, of course, you want to treat the underlying cause. If it's Shigella, Salmonella, Campylobacter, E. coli, everything other than enteric hemorrhagic E. coli, we can use ciprofloxacin 500 milligrams BD for 3 days, or even levofloxacin 500 milligrams daily for 3 days. If you're dealing with Vibrio Cholera, the go-to drug is tetracycline 500 milligrams QID for 3 days, or even doxycycline or azithromycin can do the trick. Our causes of Microbreedium, isosporobelli, and cyclospora, here we use a combination of trimethoprim, sulfamethoxazole, which is otherwise affectionately termed Bactrim, which is a combination of trimethoprim 160 milligrams and sulfamethoxazole 800 milligrams per tablet. So we take that quantity, BD, for 7 to 10 days. If you're dealing with C. diff, Giardia, Entamoeba, you're going to consider metronidazole, 500 milligrams TDS for 10 days. But of course, antibiotic-associated diarrhea in the way of C. diff toxin is a different kettle of fish, which we'll talk about another time. All right, so God bless you. This was our 60th Mnemonic in Internal Medicine, talking about diarrhea in the immunocompromised. God richly bless you. Have yourself a fantastic day and weekend ahead.